Hi, everybody. Welcome. We are so excited to see so many new faces tonight. I'm Susan Getz. I'm a co-chair of the Vassar Center Leadership Community, along with Sherry Potter, Raquel Haas, and Helene Soren, and I'm also on the Vassar Center Advisory Board. We launched this group, the PLC, to provide a supportive forum for parents of children who have or may be faced with a BRCA genetic mutation and to serve as a resource to stay informed about the latest advances in BRCA research and care. For the many younger adults here tonight, we also have the Vassar Young Leadership Council, or the YLC, a group of more than 200 BRCA-affected men and women across 29 states who come together to stay informed and provide a community of support. If you would like more information about either one of these groups, find us, somebody with the tag tonight, and we can talk to you about it. We have sign-up sheets. Tonight's discussion will focus on mastectomy and reconstruction surgery. There'll be some time for Q&A at the end of our discussion, and we'll also be addressing many of the pre-submitted questions, as many as we can. This is always a mouthful. I'd like to introduce, I'll just say, okay, our hero. That'll work. I'd like to introduce this evening's moderator, Dr. Susan Domchek, the Vassar Professor in Oncology at the Perelman School of Medicine at the University of Pennsylvania, and Executive Director of Penn Medicine's Vassar Center for BRCA. Her work focuses on the genetic evolution and medical management of individuals with inherited risk factors for cancer. And with that, I'll turn it over to Dr. Domchek.
Thank you so much. Thanks, Susan. Everyone, round of applause. Again, thanks so much for joining. And for those of you standing in the back, we have room up front, so don't be shy. So again, I'd really like to thank all of you for coming and for this opportunity to talk about this really important and interesting area. So I'm going to introduce our two panelists here, Dr. Fayanju and Dr. Rose, and I'd like to thank them for coming. So Dr. Lola Fayanju, immediately to my left, is the Helen O. Dickens Presidential Associate Professor and Chief of the Division of Breast Surgery at Penn Medicine. She's also the Surgical Director of the Runaround Breast Center at the Abramson Cancer Center, Director of Health Equity Innovation at the Penn Center for Cancer Care Innovation, and a Senior Fellow in the Leonard Davis Institute of Health Economics at Penn. And Dr. Jessica Rose is the Director of Breast Reconstruction at Penn Medicine, and she's double board certified in general surgery and plastic surgery with a primary clinical interest in breast reconstruction and microsurgery. Dr. Rose has authored many peer-reviewed publications and book chapters on these subjects, and we really couldn't ask for a better panel. So before we jump in, we're really going to try to make this interactive because, as you'll see, the three of us we actually work together all the time. There's not one discussion when individuals are considering a risk-reducing mastectomy. And some of you in the room might have had risk reduction surgery many years ago, and I think that what you'll hear is that there are techniques that have changed. Earlier tonight, I was talking to someone who said it can be really confusing because if you go to different plastic surgeons particularly, you'll hear different options. And hopefully at the end of the night, you'll kind of have a better understanding of you can go to three really good people and they might do things a little bit differently and why that might be. So to start with, just a level set, as everyone in this room knows, individuals with BRCA1 and BRCA2 mutations do have an elevated risk of breast cancer, up to a 70% lifetime risk. But there's some devils in the details. BRCA1 and BRCA2 are different from each other, and the cancer risks are different. BRCA1-related breast cancers tend to be what we call triple-negative breast cancers. They're estrogen receptor negative, they're progesterone receptor negative, they're HER2 negative, and they do tend to occur a little earlier than for BRCA2. BRCA2, the tumors tend to be estrogen receptor positive, and again, cancers occur a little bit later, but for both, the median age of breast cancer is in the early 40s. So these are, young onset cancers. But when we talk to individuals about mastectomy, first of all, we don't just think of it as, everybody has this risk, because if you're 25, your risk over the next 5 years is actually quite low. When you say 70%, you're talking about till age 80. You're not talking about next year. We also know that people have a lot of different priorities in their life. So for some women, it's really important for them to find their partner, to have their children, to breastfeed. Other women, it's really important for them to have nipple sensation in terms of sexuality and quality of life. And by the way, all of those are very important things you are allowed to factor into your decision making. I think that sometimes it can feel like this binary, like surgery or no surgery, but you're allowed to take all those things in and consider them. And so, no, it's really, I never feel like this should be a one and done conversation. This should be, and if you do not have a cancer, there's no urgency to the decision making. And so it's really important to talk to surgeons, plastic surgeons, and people like me who have no skin in the game. I don't do surgery, never held a scalpel. You don't want me to. But I think everybody has a little bit of a different perspective. So with that, I'm actually ask both of you, when you have somebody come in and they're kind of contemplating this, they have not made a decision, they're trying to sort through it, what are some of the things that you talk about?
Everyone can hear me, hopefully. I want to start by just thanking Dr. Domchek, Susan, for inviting me to be on the panel. I'm excited to see so much interest and you're wanting to know more about this experience. So, when I meet someone who is referred to me, often by Susan, to discuss whether or not they want to proceed with prophylactic mastectomy, I begin by talking about having a sense of who you are in terms of your values and your comfort level with risk. And that's because numbers don't really convey what you want your future to look like or your present, right? So if someone comes to me and they're 30 years old, they may be several things that they want to do before they proceed with mastectomy. And if someone comes to me and they're 70 years old, the question is that the time to start contemplating having a double mastectomy? For some of those people, it's driven by when you find out, right? So we actually share at least one patient who was diagnosed in her 70s because I treated her 92-year-old mother who was a new diagnosis of BRCA2. And I think that for that patient, the shock of her mother being a genetic mutation carrier really prompted her to think, I just can't take on the idea of developing cancer at this time in life. So even though her lifetime risk at 77 was probably pretty low, she did opt for bilateral mastectomy. But then I have patients who are BRCA1, BRCA2 mutation carriers who have had triple negative breast cancer twice and opted to never have a mastectomy. So I think what I really try to do is get a sense of the patient, because it is a process and a journey where often I meet these patients a couple of years before they ever have surgery. I give them my cell phone number. I let them know you can reach me when you feel ready, or if something changes in your exam and you think that you might want to pursue this earlier than you might have. And then we keep that conversation going. So I emphasize, let's figure out who you are, your comfort level with risk, what else you want to do, over the course of your life. And then we can start talking about what the surgery itself can look like.
Yeah, and just to pick up on, a few themes there, I will often be following individuals who are doing screening, breast MRIs, mammograms, and then all of a sudden one day they come in and they're ready for their mastectomy, and it's because a friend of theirs that was diagnosed with breast cancer who doesn't have a BRCA mutation, but it all of a sudden was kind of, in front of them. And this, we often call it the lived experience. If people have a very strong family history of breast cancer, where people have not done well in the family, that really is something that people take to heart. Individuals who've lost their mothers to breast cancer, or had their mother be affected when they were of an age that they could really remember the impact of going through treatment. All of these things play a role. And I wanted to say a quick comment on the difference between reduction of risk and mortality, because you would think that they would be completely related, but they're not, which is when individuals undergo mastectomy, we talk about it reduces risk by 90%, and they're going to tell us why it's not 100%. And so it's the single most effective way to not get breast cancer. But on the other hand, particularly for BRCA2, it's actually not clear that there's a survival benefit as long as you're doing breast MRI, because breast MRIs are really good at picking up early stage cancers, and most women with early stage cancers do well. But if you're diagnosed with a cancer, you have to be treated for a cancer. So all of these pieces are kind of important as people think through it. So Dr. Rose, any comments about how you approach the new person coming in your office?
Yeah, I think I have a similar approach, but I think I tend to see people who are a little bit more ready for their mastectomy by the time they're coming to me to talk about the reconstruction. And so I talk to them about their reconstructive goals, and also where they are in life, like whether or not they're planning to have children, what are the medical conditions they have, and what they want things to look like for the future. And so I think we have a discussion about what their real options are, and then I think sometimes depending on what options are available to each patient kind of helps guide when the timing is going to be right for them.
Yeah, so that leads us to a nice sort of next segue, which is, okay, so Lola, to start with, take us through a mastectomy, what it involves from your end, and what the risk reduction is.
So just talking about, from soup to nuts, you're in the operating room. There are different ways in which we can do mastectomy. Mastectomy just means removal of as much breast tissue as possible. And that can be done where someone is closed flat and they have a horizontal or a diagonal incision with an aesthetic flat closure. Someone can have a skin sparing mastectomy, which is where we remove all of the breast tissue as well as the nipple, and it comes through an incision that's made around the nipple, and then that hole is filled with either an implant or with tissue from the tummy and or somewhere else, and then closed in usually a horizontal or vertical line. And then there's nipple sparing mastectomy, which is where we preserve the entire skin envelope, and the incision is often either in the what's called the inframammary fold, directly underneath the breast where the bra underwire sits, or sometimes they can be periareolar, where you make an incision around the border of the nipple, sometimes with an extension towards the armpit a little bit of the way. And, if someone's at the point of thinking about mastectomy, we talk through which of those would be the best option for them based on their breast size, if they have cancer, where their tumor might be. And then I refer them to a plastic surgeon to discuss. Again, we try to stay in our lane, so I don't say, I think you'd be a great candidate for a flap or a great candidate for implant, though they sometimes tell Dr. Rose these things. I'm like, I did not say that. And so I say, look, all of this is based on a conversation between me and the plastic surgeon in terms of what's best for you, given your breast shape, your breast size, and what you want to look like aesthetically. And so the surgery itself, typically, we go to the operating room. Often the incision is drawn by the plastic surgeon, and then I what we call elevate the flap. So you're going to hear the word flap in two different ways here. There's the skin flap, which is the envelope of skin that's left behind after mastectomy. Then there's the flap, like an abdominal tissue or back tissue that's used to rebuild the breast. So she deals in that second flap. I deal mainly in that first flap, and so you'll hear that it can be a little bit confusing. So we do the procedure. It typically takes me about an hour and a half to do one side, and that is taking all the tissue behind the skin as well as taking it off the chest wall. If I have to do what's called a sentinel lymph node biopsy, which is to check some lymph nodes if someone has cancer, that's about 20 minutes to the case. And then often, as I'm finishing that part, the plastic surgeon comes in and can start working on reconstruction on the side that I've completed while I proceed to the other side. It's overall a very safe procedure. As I said, my components typically done, if it's a prophylactic mastectomy, usually about 2.5 hours. And then patients, depending on what kind of reconstruction they have, we at Penn typically keep someone in the hospital one night and then a few more nights longer than that if they're having a flap reconstruction. But overall, very safe surgery. People do very well. We have them out of bed walking, usually sometimes the night of.
Which is amazing. And at the interest of not staying in my lane, I would say that a lot of times the recovery, the incisions, all of this is actually dependent on the reconstruction, right? So the two of you have to work really closely together. We might get back to you how you decide on the incision in a minute, but first let's hear from Jess.
In terms of choosing what kind of reconstruction?
Yeah, well, just take us to the real basics. Like, what are the basics? What are the types?
Mastectomy types or reconstruction types?
Reconstruction.
So they basically break down into two categories: your own tissue or an implant. Your own tissue can be conjoined with an implant in certain situations, and they can be done in stages depending on what the ultimate reconstructive goals are. So I would say the majority of the prophylactic patients who choose to keep their nipple would like to do one stage, and about the only way to do that is a direct implant reconstruction. So I would say in terms of recovery, that's the most straightforward. If there's other things we need to do to modify the skin, then often it's done in 2 stages. And so at the time of mastectomy, I put a tissue expander, which is effectively a surgical water balloon, into the mastectomy cavity. And in the office, we put saline in it and grow it out to size. And then at a second operation, that gets replaced for a permanent implant. Alternatively, you can use your own tissue. The most common place we take that from is the abdomen. What would get tossed away is somebody who's getting a cosmetic abdominoplasty. We take that tissue and give a new blood supply and use that to build a breast. That's a much, much longer, harder operation, so patients tend to stay in the hospital for about 3 days, and there's obviously more than one operative site to heal. And that is usually associated with a second operation just for touch-ups, because most people's skin isn't completely even, their belly's not completely even. There's things we're going to want to do to the scars to modify things. So there's typically a second operation. If you're not a candidate for that, sometimes we take tissue from the inner thighs or elsewhere. So those are sort of the main options for breast reconstruction.
All right, I have so many questions. So first, just to talk a little bit about the abdominal flap reconstruction. That incision's a bit big, so
yes.
tell us more.
Yeah, so I make an incision from hip to hip, and then from top to bottom, usually from the area of the belly button down, and for both sides, half gets used to build each breast, and what you have is what you have. The only way to really make it bigger is to add an implant to it. Occasionally you can do some fat grafting that can add some volume, but I use that tissue, I dissect down to where the main blood supply is, and that gets cut in the at the level of the stomach. The muscles all get sewn back together. We tend to not take any muscle, but you do have to go through it to get to the blood vessels. And then that tissue gets transferred up to the chest. We shape it on the chest, and I reconnect the blood vessels into blood vessels in the chest that are usually located within the rib space. So sometimes you actually have to take a little piece of rib cartilage out to be able to get to the vessels. And because of the size and length of operations, there's usually big drains afterwards, and everything gets pulled really tight. So most patients are walking kind of hunched over for the first few days to the first week.
So I will say, you're saying this like as this is an everyday kind of dispassionate, like sure, no biggie kind of thing. But I almost equate this, I know I'm being a little melodramatic, but I get to do that. It's like a hand transplant. Like you're literally taking something with its blood supply and you're reattaching it, so you really are transplanting tissue from one side.
It's an auto transplant.
Right. So we used to, in the old days, and the only reason I mention this is because some people in the audience might have had this type of flap. They used to take the tissue and kind of drag it up and leave it on its blood supply. That's a difficult procedure because people don't have any like abdominal musculature left. So this way to do it, take the blood to reattach the blood supply is much better. So how long does it take you?
So that's a loaded question. I would say it depends on the patient. It can take, for bilateral, I would say anywhere between 6 to 12 hours, usually closer to 6 to 8, but it just depends on the anatomy.
Yeah, and so this is a big surgery. So Lola, you've talked to there's literature about this. You talk to patients about this. I mean, can you talk us about what the recovery looks like, for average patient?
So, when I counsel people about what they're going to feel like after mastectomy, for people who've had a C-section, I often explain what the numbness is going to feel like, because that is something that is a typical outcome of mastectomy. And I have had a C-section, so I can explain this. If you touch your C-section scar, your finger knows you're touching your C-section scar, but your C-section scar doesn't know it's been touched. And so that's how your chest might feel. And I explain to people that, numbness, one, is not always guaranteed, though it usually happens. Two, that it is something that can vary from person to person in terms of what numbness looks like. Is that just the absence of sensation, or is it the presence of pins and needles, like your foot falling asleep? And then it might also change over time. So those are the things I talk about in terms of how you're going to feel. In terms of recovery, I tell people that the drains are often the worst part because you're going to have, after mastectomy, at least 1 to 2 drains on each side at the top. And then if you've had the flap reconstruction, you also have drains down there. And if they're doing a flap, expect the fact you're going to have to relearn how to use your core in addition to having had surgery on your chest. And so that is in part why it's such a tough operation. But I often tell people too that once the drains come out, you start to feel like yourself again because the drains are, these appendages kind of hanging off from you. And every time you move, you're kind of aware on the inside that it's there. People are often surprised by how long they are when we pull them because they're kind of, whirling around inside there. And, I think most people after the first 2 weeks, they start to feel like themselves because by then either they're used to the drains or the drains are getting ready to come out. And then really by 4 to 6 weeks, if they've just had implant-based reconstruction, they really feel like themselves. But the flap takes a little bit longer, and Jess can speak to that more.
Just, one other comment about the drains, because this was the best hack that I ever saw, which was a husband went to Home Depot and bought a canvas tool belt. And so, and then it was also washable, and then they would just tuck the little drains in. I just thought that was the best. You can buy something really expensive, or you can go to Home Depot and buy a little canvas tool belt. Jess, tell us about the recovery from the flap, because that can be hard.
Yeah, the flap recovery is a lot more involved because you have 2 big operative sites that you're healing. So we get people up and walking the next morning. Typically, people are in the hospital for 3 days. I've had people go home at day 2. I've had people stay a little bit longer. So that just kind of depends on how well you're recovering, how well you're moving around, how comfortable you are. We do nerve blocks and surgery to try to make it a lot more comfortable for patients. Once you get home, I think that's when the real recovery starts. I second all the comments about the drains. I think that is the most challenging for patients to manage at home. All the incisions have glue, so there's not really incision care that you have to do. It's just taking care of yourself and getting around. This is closer to a 6 to 8 week recovery, especially for fatigue. And because we have to go through the abdominal muscles, I don't let anybody lift anything heavy for a minimum of 6 weeks. And so heavy is anything more than 10 pounds and ideally staying under 5 pounds. So you're not homebound, but you definitely are feeling a lot more tired and you have a lot less energy, and it takes a couple weeks to feel like you're really standing upright and that you can move around at your baseline.
And I want to emphasize just the point that you made. So you can't pick up anything like 5 to 10 pounds, which, by the way, babies, and young toddlers weigh this much. And so it actually is a real important thing that as people think through timing, actually, I often say that planning semi-elective procedures, I call it that because no one would call this elective, but because you get to kind of pick your time, it can be really complicated for people to figure it out. And when will they have help? Who can help with the kids? Because, it's actually, sometimes I think that if a 4-year-old can kind of crawl onto the couch, but a 1-year-old doesn't know why you're picking them up. So these are just things that, people have to think through with their families about timing. Another thing that comes up, I'm curious again, Jess, so oftentimes women who choose mastectomy at a really young age might not have a lot of tissue. That's just, okay, I'm a little older now. Sometimes we get a little more tissue as we get older, but sometimes they do. And so can you talk about an abdominal flap in someone who may wish to get pregnant?
Yeah. So I tend to not recommend it in somebody who may wish to get pregnant. And it doesn't mean that it's off the table. I just don't think it's a good option if you're planning a pregnancy because the scar doesn't stretch in the same way that regular abdominal tissue does. And so you've also altered the abdominal wall. So you can carry a pregnancy just as well, but the discomfort in the 3rd trimester while everything's trying to stretch through scar tissue can be really painful and uncomfortable. In addition to that, your body's going to go through a lot of changes with a pregnancy, and so the aesthetic result before and after may not be the same. So if you're planning a pregnancy, it's better to do that after the fact. So in patients who are really sure they want to have their mastectomy up front, I recommend starting with an implant-based approach, and you can always later in life change out the implants for your own tissue when it's better timing.
So speaking of pregnancy, another thing that can occur, we kind of talked a little bit about how, the idea is to take every last bit of breast tissue. And you guys are going to laugh at my analogy because you're going to be thinking it's so ridiculous. But I often say that, doing a mastectomy isn't like taking a baseball out where you take it out and it's a little bit like, Jell-O dumped in a shag carpet and you've got like little, now I know you have fascial planes and all this kind of stuff, but you don't tend to take every last little bit of tissue out, right? I mean, and that's why there is some residual risk. I'd love you to comment that, and also on the fact that sometimes then when people get pregnant, those areas of a little bit of tissue left can sometimes grow a little bit. It's something we see.
No, I mean, I think that's the reality of the body. So there is a plane. Remember, I talked about skin flaps. It's not really skin that we're leaving behind. It's skin plus what we call subcutaneous tissue, which is a little bit of fat right behind the skin that houses the blood vessels that keep the skin alive. And that skin flap, we're trying to basically have the perfect incision between that skin flap and that type of fat and the fat that makes up the breast. It's a very subtle plane. It's why people go through residency. Even a lot of people who finish residency can't identify that plane. And you're trying to find the perfect balance between getting all the breast tissue, but keeping that skin flap alive so that they can put something in for reconstruction. And so inevitably, sometimes there's a little bit of breast tissue still left behind. Even if you do a perfect operation, there's still cells left behind that can hypertrophy or grow in response to the hormone changes you see over the course of your life, particularly if you go through pregnancy. So we just counsel patients that there's a possibility that whatever residual breast tissue is there might expand a little bit. And sometimes, I've never personally had this happen, you may even experience lactation in terms of a little bit of breast tissue behind the nipple producing some milk. And again, it's not because your surgeon didn't do a good job, it's just because it's not always predictable how much breast tissue is left behind and whether it might change, God bless you, over time in response to the hormonal changes in your body.
All right, so we've talked about short-term recovery. Let's talk about long-term effects in terms of, so you've had a mastectomy. What is that like now for you? So I'll start with Lola, and then I'm going to ask Jess about saline versus silicone. But Lola first.
I don't have many patients with saline implants.
Okay. You handle long-term.
Yeah. So what I will say is I think most women who opt for bilateral mastectomy, whether that's for prophylaxis or after surgery for cancer, I would say 90% are really happy they did it. They think that was the choice for them. And I always tell people who have a choice, you need to make the kind of decision where you're not going to regret what we find on final pathology. So if someone has a speck of cancer and it turns out we're not going to find any more cancer, you did a bilateral mastectomy, maybe you didn't need to do it, you need to be happy with that decision no matter what was found. So I encourage, no Monday quarterbacking of your own life. Just look forward. I think, the numbness is important, and I think a lot of people are under-counseled about that. I have a number of patients who their mothers will have had the surgery 20, 30 years beforehand, and I will go into the conversation about numbness, about implications for sexuality, for body image, and the mom will say, no one told me. I woke up on the operating room table and had no idea this is what I was going to experience. So I do spend a lot of time talking about it, but I also want to emphasize that for the vast majority of patients, it is not a long-term problem. It's something you get used to, kind of like the C-section scar. You recognize that your body is a little different, but it's still your body. You look great, especially if we do it. I think people are really happy with the decision. So, she'll talk about this more, I assume, but obviously with implants, there's a lifetime for each implant. So typically they can only stay in for a number of years. While if you have autologous or your own tissue type of reconstruction, that does not need to be changed out. And so that is something that, depending on how old or young you are when you get your first reconstruction, you might want to keep in mind, because you want to be replacing implants at 70 or at 80, you're not going to handle that the way you would have handled an operation at 25 or 40. So just something to think about.
Yeah, so just take us through implants, saline, silicone, how if they need to replace, and contractions. There you go.
Right. So saline versus silicone, I recommend silicone implants for reconstruction across the board. I don't think I've ever put a saline implant in for reconstruction. I suppose if somebody had very strong feelings about it, I would consider doing it. The advantages to saline became popular in the 90s when silicone implants were on a moratorium by the FDA because everybody thought that they were causing lupus and autoimmune disease. That has since been debunked, and the newer implants have much better silicone technology. Saline does not hold its shape, so effectively the outside of both is actually silicone, so either way there's silicone going in. Saline is effectively a water balloon, and it looks like that. They're truly designed for augmentation to be put through a teeny tiny incision and then inflated once they're in you. That means they also weigh quite a bit more, and there's also any device that we put in you has a lifespan. So if it's saline and it ruptures, the whole thing deflates. The silicone technology now is what they call a cohesive, some places listed as gummy bear, but the molecules hold together a little bit better. So even though it doesn't really feel stiff, there's sort of a stiffness to the tissue so that it doesn't just kind of run everywhere like the older implants did. So across the board, it holds its shape better, it weighs less, and if it were to rupture, it's not going to go anywhere, and it just stays in place so you don't deflate. And I think it's a lot more comfortable. The weight of saline is quite a bit more, and so I think that's noticeable for patients. But the aesthetic results are not what you can get with a silicone implant. There's a lot of different silicone implants on the market. Some of that is by size, and then there's shaped options available. The shape options are textured, which a lot of people are avoiding now because we think it's associated with the lymphoma that's associated with implants. There's still some available on the market. They have to be textured so that they don't rotate, because if something is shaped and it rotates, then it looks very wrong. So in patients willing to consider that, I still use those. The long-term risk for a silicone implant is that it will rupture at some point during your lifetime. Most of the manufacturers say that 50% will rupture by 10 years. I have definitely seen early ruptures, and I have seen people with 15-year-old implants that are fully intact. I think there was a recommendation at one point that every implant should be replaced at 10 years. I think that's no longer truly the case. Usually around year 5, we start getting imaging, and the recommendation is when they're ruptured, they should be replaced. And how long of a lifespan you'll get out of them is different for each patient. If they're intact and they're not bothering you, whether they're 10 or 15 years old, I don't think they truly need to be replaced. If there's imaging signs of rupture, whether they're 2 years or 20-year-old, they should be replaced.
And just the FDA guidance right now, which is not super evidence-based, we'll leave it at that, but and correct me if I'm wrong, is some sort of imaging at 5 years after the implant goes in, and then every 3 years after that, something like that.
Yeah, 5 years, and then every 2 to 3 years after that.
Yeah. So just to give you so that also is part of our counseling, which is like if you're doing. Some people absolutely hate MRIs, and if they are a candidate for both, nowadays I can't tell you we're not going to image you because this is, again, this evolving area. And there's also, and again, correct me if I'm wrong, but I will see sometimes an intracapsular rupture without an extracapsular rupture. So essentially, there's 2 layers, correct? Or-ish.
So the implant has its own shell, and then everybody will form some level of scar tissue around the implant or a capsule. It's pathologic when it's firm, hard, and uncomfortable, and that's capsular contracture. But everybody has some sort of scar around anything that's put in you that's not you. If somebody has a port for chemo, you have a scar around it. So if that rupture stays within the capsule, it tends to not change the aesthetics in the interim, and sometimes it goes totally unnoticed because it's hard to feel when it's just encapsulated in scar tissue.
So let's talk about pain a little bit. So I think, Lola, it was mentioned a little bit, but we do things differently with pain these days in terms of acute management. Do you want to talk a little bit about that?
Yeah, so pain is normal. I want to lead with that because I think especially in a lot of children's hospitals, and I actually almost became a pediatric surgeon, so this is not to take anything away from that area, but, there is this idea of like ouch free, but pain is a normal feedback mechanism that tells you something is not going right, or that something is healing, or that your body's taking care of itself. And so I think, particularly in America, we're not good at pain, and we're not good at recognizing that pain is part of life, especially as more of us are not engaged in manual labor. And so going into surgery, you have to kind of counsel people. So I found that, women who've had natural labor without C-section, without epidurals, they tend to be just fine after mastectomy. But I think that, so I'll ask that. And if they say, oh, I did, I'm like, you're going to be fine. But if you, have never had surgery of any kind before, okay, the expectation is you're going to hurt. But that in general, it's easier to keep pain away than to treat it when it comes. So I encourage people to get on a regimen of alternating Tylenol and ibuprofen or Advil, something every 3 hours, almost as soon as they can swallow something. And then we offer narcotics in a much more limited fashion than we used to. When I was in training, oh my God, we gave like 60 of oxycodone for like a hernia, truly. And that was what you were instructed to do. And we were also instructed that it wasn't addictive. Well, we now know better. And so we're much more judicious. If I'm doing a bilateral mastectomy, I typically just give people 20 pills of what's called tramadol. Actually, sometimes 10, depending on the patient. Really trying to give people very little so they can be judicious, so they can lean into the fact that pain is normal, but that they'll also know when pain changes, so that something might be indicating that we need to be contacted. Intraoperatively, we always do blocks, so we inject the pectoralis and serratus muscles to try and provide regional comfort, which will typically last for at least about 24 hours. And in addition, we encourage people, as I said, to stay on the pain meds kind of round the clock and only use the amount of opioids we give to spot, really just to kind of deal with breakthrough pain. I also let patients use ice on their drain site because that is a very sore area, though we don't let them put it on their chest because we don't want to cause any type of ischemia or poor blood flow to the skin flaps. So again, we really try to acknowledge that it's going to be painful, depending on what kind of surgery your experience with pain might be more or less painful, but overall it's very manageable, and there are a lot of adjunct things that can be done to make you feel better other than relying on narcotics.
Jess, I want to ask you, because there's a lot of different questions that were submitted in advance that I'm going to try to incorporate. So this might seem like a random swerve, but for women who are larger breasted and who, who have had a few kids and maybe their nipples aren't pointing exactly where we want them to point anymore, but they're interested in nipple-sparing mastectomy. I think that's where there's been a lot of changes too. Can you talk a little bit about that?
Yeah, in most of those patients, there's a benefit of doing either a reduction or just a lift upright before surgery, and waiting 6 weeks to do the ultimate mastectomy, and that allows us to reposition the nipple into something that's I guess you'd say more ideal.
Forward-facing.
I think the problem when you do a reconstruction is it sits a little bit higher than a natural breast, whether it's an implant or your own tissue. And so as gravity takes its effects, if you have something that's sitting higher, it actually pushes everything lower. So you want to reposition it into an easier position so that it looks right afterwards. So the best way to do that is either with a lift or reduction, and then whether or not you have a lift or reduction sort of depends on what your ultimate goals are afterwards. I think I have a lot of patients that the grass is greener on the other side. If they start smaller, they want to go larger because this is their opportunity to modify something. People that are larger to start with often want to go smaller, and so that's sort of our opportunity to make that change so that the ultimate reconstruction is whatever the patient wants it to be in the end.
I think what you're hearing time and time again is like, you're a huge part, you're a participant in this. Like, you get to kind of say, and by the way, you could be smaller than you are now, you could be bigger than you are now. Like, this is actually your chance to kind of identify sort of what you want out of this. Lola, tell us a little bit more about nipple-sparing mastectomy and safety.
So nipple sparing, as I mentioned, is where we keep the entire skin envelope, and we get all the tissue out through a fairly small incision, either underneath the breast or, as I mentioned, at the border of the nipple. Sometimes people also can do it through a vertical incision just below the nipple. And, what makes nipple sparing a harder operation is that you're working through a very small hole with very limited visibility. Yet you're trying to get that perfect balance between getting all the breast tissue off and leaving the skin alive. And it's not that nipple sparing is in itself a less safe operation than skin sparing or standard mastectomy. It's that it's really important to have the person doing it have a fairly reproducible technique where they're not porpoising in and out of the plane, leaving chunks of breast tissue here, taking too much breast tissue or skin or fat other places. What you're striving to do is have as smooth and consistent a flap as possible, and not one where you're getting a little timid or you're afraid about how the skin looks and you leave too much breast tissue behind, because we're trying to do the perfect operation. Someone who has a BRCA mutation, we want to leave as little breast tissue as possible. And so with that goal in mind, it's just trying to get that perfect balance that makes it hard to do through a very small incision. So, nipple sparing is perfectly safe in someone who's not leaving too much tissue behind and who has experience doing it in a way that doesn't have this kind of uneven effect on the inside. There is a possibility that with patients who have a very, 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 very high risk of cancer of many kinds called Li-Fraumeni or P53 mutation, that there's some possible data that maybe those patients are at such high risk for breast cancer that maybe they should have non-nipple sparing mastectomy, but that data is really out. And I think that honestly, the vast majority of patients who have a genetic mutation for breast cancer, it's safe to do nipple sparing in someone who will do it properly.
And I think the data have shown that in general, if it can be done, people are much happier with their reconstructive result because it kind of still looks like them. It is their nipple, so and reconstructed nipples can look a little funny. Tell us a little bit about that. I mean, yours are perfect, I know, Jess, but tell us about, if a nipple is taken, what are the options? Because there are a couple.
Yeah. So you can build the nipple mound. That's much easier to do in somebody who has a breast reconstruction with their own tissue, because when you have tissue on top of an implant, it tends to be a little bit thinner just from having the implant underneath pushing out, and it's harder to get projection. And then most of the time now, people get a 3D tattoo, whether that's on top of a bump that's built or not. There's older techniques that some people still do where they either use skin grafts from elsewhere, cartilage grafts to actually build a nipple, but I think the 3D tattoos look better than that, and then you don't have another operative site to heal. So I think that's what most people choose to do now.
I will tell you, the 3D tattoos can be absolutely astonishing, if anyone has seen them. And then the other, weird thing is that particularly if you have implant reconstruction, oftentimes people don't need to wear a bra, and then if they have sort of a created nipple, then if you will, they're always on. So I mean, these are kind of things to consider, right? When you're thinking through this. But again, it's lots of different choices. So one thing that we're going to talk about next is always kind of a weird thing, but there is in medicine, we would love to never have a complication. We would love to give chemo every time and never have anyone have a problem, or do a surgery and never have a problem. But complications happen, and it's complicated. Everybody comes into surgery with different potential risk factors. So I think the really important thing is, as you're talking to surgeons, and we'll kind of go through some of that discussion in a minute, but you want to also hear about how do you manage complications? Because if somebody tells you that they've never had a complication, you should not go to that surgeon because it's not true. So starting with you, how do you deal with that?
I tell everyone that anything can happen in surgery because life is not predictable. And as Susan said, you should not trust anyone who says they've never had a complication. We actually say in surgery, if you're not having complications, you're probably not operating enough because you're maybe being too selective, or you just aren't having the volume of patients, because the law of numbers would indicate that you should have at least a complication, but never a new. I just tell people that what matters most is obviously not just avoiding the complication, but how your doctor responds to a complication. The tendency, because we're human too, is to want to run away. But what I really love about, good plastic surgery partners is the ones who lean in. And I lean in. That's the patient you call more, the patient you bring in more, the patient you have to face your own vulnerability as a surgeon, that you're fallible, that you make, things don't go perfectly. And just really being present for the patient is incredibly important. I try as much as possible also to kind of counsel them about all the things that can go wrong, not just bleeding, infection, etc., but that you could have a freak allergic reaction to something and that can cause a horrible rash. Or, in the worst case scenario, you have a thinning of the skin and we have to resect some of the skin or even the nipple. That's obviously very disappointing. But always emphasizing that no matter what happens, I'm your doctor and you're my patient and we'll get through this together, I think is the most important thing. And again, the fact that you need to lean in, that's not when your surgeon should be abandoning you. It's when they need to be more present for you than ever.
Jess, any comments about the complications are a little different, flap to implant? I mean, some are the same, but any comments?
Yeah. I think the most common thing we see in breast reconstruction is implant infections, and it's primarily because you're asking thin skin that's just had surgery to protect a device, and sometimes your skin just doesn't function as an immune organ the way we would like it to, and things get infected. I think I have a very, very low threshold to take people to the operating room and wash it out and replace it with a new implant. But I think if you manage things as quickly and efficiently as possible, I think your rate of salvage is much, much higher. I think that's the most common thing that can happen. For flap surgery, the most devastating thing that can happen is that the blood flow doesn't work and the flap dies and you have to take it off. I think prevention is sort of the biggest thing for that ahead of time, is talking to people about what their other risk factors are. So somebody who has family history of blood clots, or has a clotting disorder themselves, or has significant diabetes or a substantial smoking history, anybody that might have some sort of vascular disease is going to be a higher risk for having that sort of complication. And I think having that conversation with those patients ahead of time and maybe deciding that that may not be their best option ahead of time is the thing to do. The other option is keeping some people on blood thinners to try to prevent things from clotting, but that may mean you're taking a trip back to the operating room for bleeding because you're trying to balance somebody who wants to form clot and giving them blood thinners to prevent that, but then trying to keep them from bleeding in the immediate postoperative period. That can be pretty challenging. So I think obviously prevention is sort of key, but sometimes it's just screening people ahead of time to have an idea of what their tolerance for complications is going to be. But the most common thing I see is implant infections, and it's frustrating for patients to have to go back to the operating room, especially early on. But I think if you do that, you can get a successful reconstruction.
One last thing about complications is you're almost going to certainly meet the entire team, both prior to surgery, but also after surgery. And that doesn't mean that your surgeon is neglecting you. You're going to meet often an advanced practice provider that is a nurse practitioner or a physician assistant and a nurse and maybe an MA. Like, you get to know the team if you have a complication because all of us are invested. That might be who answers the phone. And so just want to prepare people for that, because it may be that we're scrubbed. We're in the operating room, or we're at a work conference, or we're in clinic. So there'll be a team of people who will be helping you with the complication. But that doesn't mean you don't have a right to see your surgeon as well. I want to put that out there. Sometimes it does feel like patients are turfed and they don't see their doctor when things go wrong. Like, that is your right. But understand that just because you aren't seeing the doctor every single time, or that's who you're always speaking to, doesn't mean they're not invested or care. And you have a right to see them and talk to them.
I mean, the best thing we can do as physicians is be there for you, not only when things go right, but when things aren't, don't go perfectly, as much as we try for that. So I want you to kind of envision, like, you've talked about a bunch of different kinds of incisions, and you've kind of alluded to the fact that it kind of depends on what you guys are doing together. How does that work for you? Like, when do you guys talk to each other? So you both see a patient, and how long does that take? Does that take 30 seconds because you've done it so much together that you just, how does it work?
I mean, at this point, it probably does take 30 seconds. I would say in a patient that's going straight to mastectomy that doesn't need a reduction up front, most of the time it has to do with what the ultimate plan is, presuming the patient is nipple sparing. I generally make the call because occasionally there's ways through nipple sparing that I can use the incision to do a little bit of a lift at the time of mastectomy. So I usually just shoot Lola a text in the morning, hey, this is what I'm thinking about drawing for the incision. What do you think about that? And most of the time she said, yep, and then that's that.
And that's that.
So I think at this point we've done enough of them together that we sort of have an idea of how they go. If I'm working with somebody I haven't worked with before, then it's a conversation that usually happens earlier. I think now with the electronic health record, it's very easy to just send messages back and forth that this is what I was thinking about doing with the patient, and we all get on board to make sure that that it's going to work for everybody involved.
In addition, if I'm seeing, particularly with cancer patients, I might send a text, not a text, but I'll send my note from the initial consultation and say, not oncologically safe for nipple sparing because the tumor might be right behind the nipple. Or I might say, concern for, or I'll also signal before they see the patient, this patient seems to be interested in implant-based reconstruction. This patient seems to be interested in something called Goldilocks, which is where we use only your skin to reconstruct the breast, and there's no implant, there's no tissue from your tummy borrowed from anywhere else. And so priming your partners for success is also helpful, like that, you have an ongoing relationship, but that you also kind of let them know what the patient's already discussed with you so that the conversation will be more focused on what their goals and their intentions are.
And I think most of you in the room may know this, but I think the amount of, it really does take a village. So we have a conference call, every week for our tumor board. And on that call every week is, the radiologist, many radiologists, but radiology, pathology, surgery, medical oncology, radiation oncology. We get plastics in. We'll have the nurse practitioners, rehabilitation medicine. It really does take a lot of people to sort of get people all the way through these things. And again, you don't need a radiation oncologist if you hadn't had cancer, but all of these things really matter. And so we bring these complex cases. This is where I will say that COVID-19 was horrible, but we've gotten really good at these case conferences and in terms of the technology and being able to look at all the imaging. And so just know that we are, not in a bad way, we're talking about you because we're trying to get the best plan for you for sure. Okay, so let me think of, I wanted to definitely talk about that. So for contractures, let's talk about contractures a little bit and when do you decide to operate on something like that? So these again for implants.
Yeah, most of the time if somebody has a capsular contracture that either looks concerning, is uncomfortable, I tend to operate on them. I would say, there's nothing emergent about the nature of it, so it's something that I can have the conversation with the patient so that it can get scheduled around whatever activities you have going on so that you can, if you want to travel, you do that first so that you have time to take care of it afterwards. But most of the time, it's really hard to treat it without actually operating on it. So I have a low threshold to take somebody back to get them more comfortable.
And I think one of the things that I've experienced over time is that you can have individuals, this is getting it back about what Lola said about what people are trying to get out of this. I can see patients sometimes that really haven't had great reconstruction, not by Jess, who's is perfect, but they're totally fine with it. They're like, I am fine. I do not want to have another surgery. Yes, I have some contraction on this side, so it looks a little asymmetric, but it's not uncomfortable. I don't want to have another surgery. My husband and I are the only people who see me naked. I look fine in a bathing suit. I'm fine. And there are other people who are very sensitive to this. And so there are ways to do touch-ups, like fat grafting and things like that. Do you want to say a word about that?
Yeah, it's complicated because it depends on what everything looks like, what the options are to change a previously done reconstruction. But I think there's a lot of options for revising it. Sometimes it's just changing the implants. The implant technology gets better over time, so the size may not have been quite right. You can change out implants for your own tissue potentially, so it depends on the nature. I would say there's some people who I'd basically start over from scratch depending on how significant the problems with their reconstruction are. There are people who just have implant malposition, so sometimes I put similar sized implants with some sort of mesh to hold it in place to basically build them an internal bra and get a better result. There's some people that just have some rippling, there's some contour abnormalities, they might be good candidates for fat grafting. So there's a lot of different options, particularly depending when the original reconstruction was done, because if it's something that's 30 years old, the technology is probably a lot better, and it may not actually take a lot of work to make a significant change.
Another question was, if you're too thin for a flap, can I gain weight before I, how well does that work for you guys?
It doesn't work very well because most people live at a certain weight, and so it's fat that's getting transferred. So if you gain weight for the operation, you might get yourself through the operation, and then when you lose weight to get yourself back to wherever you normally live, it will also shrink. So it's not really ideal. I've definitely had people ask if they can just eat nothing but ice cream and make that happen. And I guess you could, but the likelihood of it shrinking over time when you get back to whatever your baseline is pretty significant, and then it's not going to look like what your ultimate goals are.
Yeah, and just to put a point on it, yeah, flap reconstruction gains and loses weight like as you gain and lose weight. So it's kind of unlike implant reconstruction, which obviously does not. Which is,
and there are no transplants. I sometimes have husbands who want to donate their own tummies, and I'm like, I said, talk to Dr. Rose. Not really. No, I tell them that's unlikely to be an option.
It's only an option if you have an identical twin.
Yeah. Well, a comment about going flat, because some people are definitely choosing that.
Yeah, no, so going flat is increasingly an option for patients. And, I think it was, Jess just said, patients, the grass is greener on the other side. So a lot of my patients who want to go flat are people who are very large-breasted and have hated their breasts their whole lives, and they're like, I want them gone. I also have patients who may be trans men or non-binary who want to go flat and don't want any kind of reconstruction. And so our goal is to create a very aesthetically clean, flat, minimal, kind of what we call dog ear on the edge, that is extra redundant tissue, that would allow them to have basically a flat surface in a shirt. Or if they want to go flat but still have a prosthesis, that would allow for a prosthesis to sit comfortably on their chest. One of my patients at my former practice was 80 years old and got her first tattoo after her flat closure. She got a big tiger over her chest. It was awesome. And, there is actually a very famous picture of a woman who is with Breast Cancer Canada, their big organization there, where she has sunflowers across her chest. You may have seen this picture. And it was funny because I met her at San Antonio Breast Cancer Symposium, and I recognized her face, and I realized I recognized her chest, but you don't want to say that. But she recognized that that's what I was thinking. And she's like, you probably know me from. So that's all to say is that flat closure is a very reasonable option. A lot of women are increasingly choosing it. One of my best friends from medical school chose that, actually, because she wanted to get back to playing tennis as soon as possible and is really happy with it. So that's something can either be done by a breast surgeon like me or sometimes in collaboration with the plastic surgeon, particularly if someone has a lot of redundant tissue, or it's basically if they have a lot of redundant tissue on the side, or if they're quite small-breasted but they're a bigger person. Those are people who are more likely to have excess tissue on the sides that may not come together as naturally.
Okay, I do have some more questions, but we have a question from the audience, so go for it.
Thank you. I have two questions. The first one is I would like it if you discuss pregnancy and timing more, because my sister-in-law died at the age of 39 after having her second child. Now that was before we had information for BRCA, and she was BRCA positive, but having two children obviously stimulated her hormones, and she had a hormonal type of cancer. So timing and whether you could get pregnant or have a surrogate, which I personally as a mother think is the better choice, how you feel about getting pregnant altogether. And the second question I have is, if you have a child, a daughter, who's BRCA positive, and you're not, but you develop cancer, as I did, does that increase the risk of your daughter getting
Yeah. So there's a couple of things in there. One actually is an issue I was going to kind of raise at the end, which is your second question, this kind of individualized risk prediction as we talk about it. Because we generally counsel people kind of the same way, 70% lifetime risk of cancer. If you're 25, less than a 5% chance of cancer over the next 5 years. We have these numbers that we give. We do know that there are other things. There are things called SNPs, single nucleotide polymorphisms, which are really tiny changes in other genes, but we now know about 313 of them, all of which slightly increase or decrease risk. So any one in isolation doesn't really matter, but if you have all 313 good or bad ones, it can modify risk a little. We've been doing a study with Memorial Sloan Kettering on giving that information back. The challenge is that for most people, it doesn't change the risk very much. So it's hard to see that in isolation is going to do it. But what we're looking for is there are also different mutations in different parts of the gene of BRCA1 or BRCA2, because there's many, many mutations in BRCA1, many, many mutations in BRCA2, and depending on the location in the gene, that can slightly increase or decrease your risk. Family history can slightly modify your risk. Reproductive factors, which I'm going to get to in a second, can modify your risk. So what we'd really like is a model, an individualized model to tell you what your risk is next year or in 5 years, rather than this ridiculous lifetime thing, which is hard to get your head around. We are also hopeful that machine learning, we say AI, but often we mean machine learning, like looking at mammograms and MRIs, that we could predict risk, like a short-term risk of developing cancer. So we're working on all those things. We haven't figured them out yet, but we are working on that. So family history doesn't play as much of yes, it increases your risk, but not so much that it generally changes our general counseling. Pregnancy is complicated. Overall, it decreases breast cancer risk. Okay, so pregnancy, in sum, decreases breast cancer risk. It is also true that in carriers and non-carriers alike, there is a tiny blip around pregnancy. It is a small blip, and it's complicated. It's not so much just pouring on the estrogen. It's not like that. Mostly, these are probably cancers that were already existing and then kind of took off. So these days, we feel, and again, these are individualized decisions, but we make sure people get their MRIs. And I often say, I want to know first what your pregnancy plans are, because I want people to get an MRI before they get pregnant. We can't get an MRI during pregnancy, but we can get an MRI during breastfeeding, and we can get mammograms while pregnant. So this is all part of the counseling that we have. But no, I don't feel again, we are happy to work with you. We work for you. So the question is, what are your goals? And we'll work with you. But we don't generally say that people can't get pregnant, if that makes sense. Yes, we got a question. Yes.
Just going back to the mastectomy topic, are there things that a patient can do in advance of a mastectomy to sort of prevent this idea of infection or set them best up for success in terms of recovery? I'm thinking very selfishly, what are the things that I can do to prepare myself?
Great question.
I think avoiding adding risk factors to your life that make complications more common. So if you don't smoke, don't start. I think people who are just in better physical shape do recover better. So, do that plank, I guess, or, stay physically fit so that it's just your body's better able to recover from what is going to be a big, change for it. I don't know if you have anything else.
I would add nutrition. I think a higher protein, high nutrient diet will help, because your body's going to need a lot of that while it's recovering. So starting that ahead of time can be helpful. But outside of that, we wish there were more things we could have you modify to decrease risks, but they just sort of exist.
I will also add the psychological component. I actually think lining up your posse is really important, and actually having very specific things for your posse to do. Because people will say, let me know if I can help. And that's this vague, useless kind of comment. So you can say back, hey, if all of you want to get together and hire me a house cleaner once a week, that'd be great. Or, meals a couple of days a week would be great, but please not always lasagna. Or, can you have a play date for my kid? And I mean, very specific things, and line them up ahead of time, because those first 6 weeks are, especially if you get a flap, they're pretty rough, and you're going to want people sort of surrounding you and helping you out. And I think, Sherry, did you have a question?
I'm
can you speak at all, because I think we read somewhere about some technique that they do now to preserve, to get.
Yeah, nerve sparing. Yeah, I have it on my list. Sorry, but it was good because people had questions. So
to increase the possibility of your nipples surviving, the nipple sparing.
that's a little different. So we got nipple preservation and nerve sparing. Let's start with nerve sparing. Lola, tell us what you think about nerve sparing.
So I think, as I mentioned, that the loss of sensation is a big thing to consider when you're going through mastectomy counseling and making a decision to do it. It's variable. Most people are numb, some are not. And so there have been techniques looking at whether sensation can be preserved or sensation can be kind of added back with grafting. There is some concern that in order to preserve the nerves, you're going to have to leave behind enough tissue to carry the nerves. And as I mentioned, what that subcutaneous tissue primarily covers and carries is blood vessels, not really nerves. Those are typically transected as part of the operation. There is a little bit of suggestion that, again, sometimes if you're doing a robotic mastectomy, which again I want to put out there is still experimental, that might have slightly improved sensation. But I think that these are all still highly experimental things where, sensation may be preserved or added, but at what cost to risk reduction? And I think that remains a balancing act. Is this?
There's something called allograft nerve tissue called resensation, which is actually a brand to do this, which is not actually preserving what you have, but adding on a porcine allograft. Can you talk to that at all? What do you think of it? Because I have different.
Yeah, so so I would tell you that some of the data is controversial because it is put on by that by the company that owns the nerve graft, Axogen. Essentially what that is finding nerves in the chest and putting the grafts in to reconnect to the nipple. Can you restore sensation in that fashion? Yes. But is it the same sensation that a nipple had before? It's not, and it can't be because you're using a nerve that's meant to basically provide sensation to the chest wall and asking it to essentially provide different sensation and erogenous sensation, which it can't really do. So you can resensate. There are some issues. You can actually cause hypersensitivity along the graft line as well. And you are putting in something next to potentially an implant. With your own tissue, there are some options for restoring sensation with nerves that already exist in the abdomen. Same situation. It won't be the same sensation, but you can maybe redevelop protective sensation. But if you're putting in a graft of something, you're putting in another prosthetic near a prosthetic. So it does increase the risk of infection as well.
Okay, go ahead.
Is there like a how and why at all?
Just a question about necrosis, like skin necrosis we're talking about? Yeah.
Skin necrosis is essentially just skin death. So the blood supply to everything has to be maintained or it does die. So part of that, I would say, is incision placement. Part of it is appropriate choice of operation. Part of it is timing. If it's somebody that has a reduction up front, you have to give the blood vessels enough time to regrow. If you do it too quickly, you will definitely cause some level. And some of it is just being able to do, some people's skin's really stretchy and it allows the operation to be done more easily. And some people's it's really firm and it's really difficult. And so occasionally just the retractor, which allows visualization, can cause some necrosis. So there are situations where it's very challenging to prevent, no matter how good the surgeon is. Other things can increase that risk, diabetes, smoking, anything else. So I think we do our best to counsel people ahead of time that are high risk for having that happen. But unfortunately, the risk is never really zero.
And I think this gets at, I love that there's so many questions. I think this does get at an issue, somebody said you can go to 3 different plastic surgeons and get different sort of answers. I think you're getting a sense of why, right? Because I guess, Lola, you won't have the same incision for every patient.
Yeah, and I joke, nipples want to live. That for the most part, even if they look a little suspect, post-op day 1 or after a week, most of the time they pull through a combination of communication between the plastic surgeon and the breast surgeon. So, yes, it's about our technique getting the tissue off, not damaging the blood supply underneath the skin, but also, how much would that expander be inflated or the flap be such that it's providing pressure from the other direction. So it's a yin and yang, in terms of working together. And then there are things that we can do that help with blood supply, including certain types of paste, et cetera, that can help the blood supply remain good even early on when they've just been a little bit banged up. So it comes back to communication from the patient, letting us know if something isn't looking great. We'll never be upset to hear from you. And then communication between the surgeons so that we also kind of work together to do the right thing. So that's helpful.
Definitely. Mindy.
A few, hopefully rapid fire. What type of imaging do you need to do in order to check your implant to see if it's still in good shape? Do you do a sonogram or does it have to be an MRI?
So the FDA recommendation is an MRI, but you can do an ultrasound, and so some people are recommending that, but the FDA requests MRI, but you can certainly see ruptures with ultrasound as well.
One other thing that didn't come up was PT.
Yes, I know.
That was extremely helpful. Much better outcomes.
Yeah, so, physical therapy is incredibly important. It's striking a balance between the movements of physical and occupational therapy. Physical therapy is kind of macro movements, occupational therapy is micro movements like your hands, and not putting your incisions at risk for rupture. And so that's the kind of balance we're trying to strike. As part of our program, almost everyone goes home with home health, where there is a nurse coming a few times a week to take a look at the incisions, looking at the drains, making sure everything's okay. And often as part of home health, there's also occupational therapy and physical therapy. But communication, there might be limits on what we allow them to do depending on whether the drain's in and how far out people are from their operation. But I think once patients are cleared, their drains are out, they've been cleared of all activity restrictions, physical therapy is incredibly important. Not only do we have physical therapists who are certified lymphedema specialists, which is really important because the best way to treat lymphedema, at least historically, have been prevention with exercises. We also have a wonderful PM&R group, or physical medicine and rehabilitation physicians who are trained in helping the body return to function after an injury or a change. And those people complement what physical therapy does and are often who we send patients to if they have a kind of limited mobility after surgery, which again is very rare, but needs just additional kind of TLC with getting back to their full selves.
We're doing rapid fire. Go ahead, Blue.
Okay, I have a few, so I'm going to rapid fire them to you. Under the muscle versus over the muscle, is there the difference behind that?
Yeah.
Traditional was underneath the muscle. I think most people have moved away from that. I said, particularly in prophylactic cases. I would say there are still specific reasons to maybe need to put something underneath the muscle, particularly in somebody who has cancer as opposed to for prophylaxis. But now with fat grafting techniques, with better implants, most of the time we do it on top of the muscle. I can't recall the last one I've put underneath the muscle. It's been a long time.
Great, thank you so much. Great, 2 more questions. With capsular contracture, is it permanent, and what percentage of patients get it?
Presuming no radiation or other treatments, I would say it can range between 5 to 10%. It can be permanent. It's something we don't fully understand. In patients who have recurrent capsular contracture, there are some medication regimens we recommend to try to prevent it from coming back.
And my last question, it's a little, tangential, but I know that you're working on a vaccine, and obviously a lot of us would love that to work and not have to do the prophylactic surgery. But I guess, number one, is that realistic that it's potentially we could wait for this? And I know Mike, you heard the answer now, but I'm curious. And also, related to that, in terms of like doing IVF and PDTM, potentially implanting a girl, especially with the BRCA gene, is the vaccine something that maybe they wouldn't have to deal with this the way
easy questions. I mean,
Chip off the old.
we are, we have multiple shots on goal, right? So we're trying a bunch of different things. There is this medication called denosumab, which is a bone strengthener medication, but actually may decrease the risk of BRCA1 related breast cancer. There are these PARP inhibitors, like it's possible that we could give them intermittently at short doses. We use them for treating cancer now, but maybe we could use them for prophylaxis. And yes, we've completed enrollment to our vaccine trial, but this is a small study. And honestly, the type of vaccine we're giving is with electroporation, is an electrical shock. So we're looking at other developing other types of vaccine strategies all simultaneously. So do I think that we're going to get there? Yes. Do I think that if you're sitting in the room right now, I'm going to know that in the next 5 years? No. And that's just being realistic. Do I hope that, if you have a child who has a BRCA mutation, that they'll have better choices? 100% yes, because I look at how far we've come now, and I really think that's true. And I'm sorry, I do work really hard, and I'm sorry we haven't made progress faster, but I understand that. But it's hard. The single, we had a whole session on fertility and IVF, and I do think it's important to say that they're valid things to do, but sometimes people are left in a situation where the embryos that they know they have BRCA mutations, or they can get pregnant spontaneously and not know, and that's okay because you're in this room, and we can manage this. It's not perfect. People have to make hard decisions, but I think again that priority board, where is having biologic children on your list, and then we'll take care of you on the other side. So I know that wasn't a very satisfying answer, but I'm working hard. I will keep trying. In the back.
Can you explain what makes somebody a candidate for doing the tissue implantation, the flap method versus the other, regular implant, especially if you are fine with having a very small size?
Yeah, maybe we haven't really touched upon it, Jess, but maybe just talk about alternative flap sites really quickly.
Yeah. So, I think when I examine somebody, I show them what they have, and we have a discussion about whether or not it's realistic to get them their goals. And so if you're small and you have a small belly and it's going to be the size that you want, then you'd be a candidate. There's other places you can take tissue from. I would say the next secondary site would be thighs, inner thighs. There are large operations with real recoveries. So what I would counsel you is that you have to have enough tissue to get the goal that you want to be worth going through that kind of recovery. So it's the kind of thing we examine in the office. I show you your operative sites and I tell you what I think you could get from them. And if it's not going to be what your goal is going to be, then I would recommend not doing it, just because it's a really long recovery, and to go through that and not have the result that you want tends to not be worth it. But yeah, a lot of people have something that's proportionally appropriate for them.
So people generally could be a candidate for this if they wanted to be, maybe?
You have to have enough laxity and enough tissue to be able to do it. And so I would tell you, it's not something you can tell by looking at somebody with clothes on. So you have to examine somebody, but I can give you, when I examine a patient, I let them know, like this isn't an option at all, or it's an option, you'd be maybe smaller than what your goal is, and this is about the size you get, or you have enough. So.
And things like latissimus dorsi flaps, they're used when you're covering an implant or something like that. They're not usually used for primary flaps. Again, I'm making stuff up, so you can tell me.
No, lat flaps you could use to cover an implant. I would just say, one, you're sacrificing an entire muscle on both sides, and so there will be some effects of doing that. In addition, it's not a ton of volume. And once you've detached it, it loses a lot and it atrophies because it's not in use anymore. So to try to get a full reconstruction out of the latissimus is pretty challenging in most patients. They just don't have that kind of volume. It's better used if you have to resurface. So somebody had a complication, or if somebody was a cancer patient that wasn't a nipple-sparing candidate that needed skin resected, it may be an option in that situation. It's not a great primary option anymore.
And people who are really intense athletes, there is some, impact Right.
Yeah, I would say people who climb things for a living, probably not any linemen in this room, but that would be a career option that I would say you shouldn't do that to yourself because you'd notice. People who swim a lot or who do anything where they're pushing, pulling, and using their latissimus excessively, you will probably notice. I've taken care of some kids that I've used it for other types of reconstructions, and they function normally over time because they adjust to it. But there are definitely some things that, especially early on, you'd be limited. So I would say it's not a great first-line option.
Yeah, one last question, because otherwise, yep, go ahead.
It has to do with babies after flap. So initially my understanding was it was a no-no because they went through the muscle, but several surgeons have said there are aesthetic reasons perhaps why it's not the greatest idea because you get stretched out and pressure, but other than that, you're not going through the muscle anymore, so you can totally have babies.
And you're not taking and using the muscle, you have to go through it to get to the blood vessels. So you actually have scar tissue in a few places, one on the skin, but also on the abdominal wall muscles. And so stretching that out after it's already been scarred, it can be very hard for those muscles to recover and to regain their function and get back to it. If you've had a flap and then a pregnancy, it certainly happens because people have had unexpected pregnancies after doing the surgery. It's much better studied in people who had cosmetic abdominoplasties because that's more common, or at a certain point in time was more common. The scar can be incredibly uncomfortable during the third trimester, and things don't stretch symmetrically the way they naturally would once they've been operated on. So it's not really recommended. If it happens, there's things we can do to get you through it. But if it's part of the plan, I would say it's something that should be weighted and done after the fact.
Especially because it sounds like you might ultimately get a better cosmetic result just by doing a short-term implant, longer-term flap.
What does that do to your scarring though if you have an implant first and you have those scars and then you do a flap afterwards? You're going.
Usually nothing because you still have to do the breast surgery at some point, and so I have to put the flap in somehow. So most of the time, depending on how the original operation was done, you can use the same scars. So you don't get additional scars on the breast typically. Yeah.
All right, with that, I want to thank everybody for their great questions and their attention. All right. Thank you, Lola. Thank you, Jess.